I don't know, Irini, if I promise that I will only speak for each case for 5 minutes, so like 4 cases, 20 minutes. Can I also present the other cases that we didn't present yesterday? I don't know if actually you would like to hear about the cases that we had yesterday, like diminished ovarian reserve and fertility issues. Should I have it in Greek, but I can speak in English. Or you prefer to have it in Greek? I don't know, whatever you say.
I prefer in Greek.
Okay.
No, please in English, otherwise I miss everything.
Okay, can we have should I start with this one or, no, let's go for the premenstrual and then go on to the other one. Okay, yes. Okay, actually, yes, PMS, it's a problem, as I mentioned earlier, not only for the woman. I mean, first of all, the most important person is the patient who is suffering from PMS, but also it's a problem for her family, for the people that she's working with. It is really a problem. So the first case, and I promise that it's going to be only 5 minutes. It's a 43-year-old woman that she reports gradually worsening PMS symptoms over the past 18 months. Her symptoms appear in the 7 days before her menses, then resolve completely at onset of bleeding. Symptoms include hot flashes, breast tenderness, mood swings, and a cyclic weight gain. Menses occur monthly, but sometimes last 9 days with variable spotting. So this is the first case. So the first question is, can we see a 43-year-old woman that now she's actually is having worsening of PMS symptoms during the past 8 months, or it is only a disease of reproductive age women like less than 35 years of age? So actually it can happen at this age, so we should have it in mind. They can worsen during the perimenopausal time, and we mentioned even earlier that depression is more common and all these symptoms. So her symptoms appear in the 7 days before her menses and then resolve completely at onset of bleeding. As we mentioned earlier in my lecture, it is very important to have this calendar in order to document the diagnosis of PMS. And I already mentioned that you give 2 30-day calendars, and even if it is not obvious in the second one, you give a third one. So it is important that we have documented that indeed it is a PMS. What about hot flashes? Hot flashes actually occur when we have fluctuations, abrupt fluctuations of estrogen. For example, girls who have primary amenorrhea, they do not have estrogen, but they do not have hot flashes. Once we will give them estrogen replacement therapy and we discontinue the treatment, then they get hot flashes. Another example of having hot flashes are women when they are about to give birth, when they are in a term pregnancy. And I'm sure for all of us that we are gynecologists, we have seen women who are in the end of the 3rd trimester, that actually they can even walk during snow time and when it is freezing outside, and they have their coats in their hands and they feel these hot flashes. So hot flashes is a symptom when we have an abrupt change, either big increase or big decrease in estrogen. So because she's 43 years of age, so maybe what the problem is that during some cycles she has normal ovarian function. In some cycles she has a dominant follicle producing some estrogen, but there is no ovulation, there is no LH surge, so she has estrogen but she does not have a progesterone. And in some cycles the ovaries stop working for a period of time, so for this cycle she doesn't have neither estradiol nor progesterone. So because she reports hot flashes, we assume that during some cycles she does not have any ovarian function at all. Breast tenderness, indeed, it is a symptom of PMS, and mood swings and cyclic weight gain also. And we do have patients that they say, you know, I'm waiting for my periods and I'm really looking forward to have my periods because once they occur, I have my normal weight again. So as this is what I mentioned, estrogen deprivation, breast tenderness, PMS symptoms. And actually, what she says, because we mentioned that probably because you have hot flashes, you have anovulatory cycles. She says, I have menses every month, but sometimes they last 9 days with variable spotting. So this is a symptom that there is no normal luteal function, there is no production of progesterone for 14 days. She has an ovulatory dysfunction because of her age. Maybe she's entering perimenopause. Her lab results, her FSH levels are 35 and the late 20. Estradiol is 30. It shows some follicular activity because if it is less than 20, you can say there is no follicular activity. TSH and prolactin levels are normal. Transvaginal ultrasound normal findings. Pap smear normal. Mammogram normal. Liver panel normal. So can we use for this woman this oral contraceptive pill? Because actually the perimenopausal women, if they have no contraindication, can have a contraception even for this small risk of having unwanted pregnancy. And this is a good pill for her symptoms. So this particular patient actually smokes 20 cigarettes per day, and her BMI is 31. So she has two good contraindications for having this option at this age. If she was a thin patient and she did not smoke, I would say this is the best choice for her because it is a low dose oral contraception, and it is shown that it is an effective pill for PMS. So it could be a very good choice, but not for her under these circumstances. So the answer is no for this particular patient. So definitely we should give her a proper counseling for exercise, for proper diet. If she is willing to lose weight and stop smoking, then we can think maybe of this oral contraceptive pill. However, for this time, we should talk to her about using the IUD with the levonorgestrel or giving transdermal estradiol with continuous combined use of progestogen. And Tibolone is not an option, not only because she is obese, but also because for perimenopausal women, it can actually induce more bleeding. So the second case, it's a 45-year-old woman that she reports irritability, periods of crying, mood swings, and severe fatigue beginning 1 week before the start of her menses and ending within 3 days after its onset. The symptoms have begun when she was 17 years old. She was quite young. And she says that she has received oral contraceptives containing drospirenone for 15 years, from the age of 30 until the age of 45. It was a good option because she was thin, she was not, she had a normal weight, she did not smoke, she had no contraindication, she had no risk factors for thromboembolism. And she was doing actually fine by using this oral contraceptive pill. But now she says that she's afraid of taking contraceptive pills for a longer period of time because some doctors have told her that it's time to stop. So from the first two things that I have here, I think we can be sure that the diagnosis of PMS has been made correctly ages ago. And the fact that she has received this contraceptive pill, it was indeed the first choice for her, apart from her good lifestyle that she indeed has. She is thin and she's not smoking, and she is having whatever is her testing for having contraceptives. So what about this time that she's taking for 15 years? There have been so many studies about the risk of breast cancer in women taking oral contraceptive pills. First of all, we must say that it is well established that by taking oral contraceptive pills, there is a decrease in the risk of endometrial cancer, and there is a decrease in the risk of ovarian cancer. What about breast cancer risk? And there are, in order to look at this thing, we have to think that most of the women who are using oral contraceptives, they're not using it just for contraception, they also have another medical condition. So whenever you have a breast cancer case, you have to check whether it is just because she was taking the oral contraception or it's the underlying medical condition that made the woman take the contraceptive. But anyway, I choose just to show you in a few seconds one study published last year in New England because of the large number. It is a study in Denmark. It had all women between the ages of 15 and 49. Because there is a good registry. It is one of the countries that they have good registry, something unknown in Greece. It almost has 2 million women. And the follow-up was about 11 years. So during this follow-up, they had almost 12,000 cases of breast cancer. So what is the findings of the study? First of all, I think it is quite reassuring because they found only one new breast cancer case almost per 8,000 women who used hormonal contraceptives for a year. And especially for women who were less than 35 years of age, there was only one additional breast cancer case for every 50,000 women who used hormonal contraceptives for a year. So, especially in this group of women who are less than 35, I think we can say that it's quite safe to use it at least for a year. But of course, there is no question 15 years is a long time. So she has stopped by herself the contraceptives for 3 months. Her FSH levels are 80, LH 56, estradiol 35. She has a normal mammogram, normal pap smear, liver panel, and transvaginal ultrasound findings. So at least from these findings, we can tell her that she is entering her perimenopausal years. And she needs a proper counseling, and I think also for this woman, because she is thin, Tibolone may be a choice, although there is risk for this abnormal bleeding. She can use continuous combined HRT with estradiol patches and progestogen, and also there is a hormone replacement therapy regimen by using continuous combined form and having a progestin with drospirenone. And this is the first part of the cases. I think I am on my time, so as I promised. And in the second cases, the second part of the cases who are women with diminished ovarian reserve. Can I have this? Thank you. I'm going to say it in English, but unfortunately it's in Greek because I had it ready yesterday. The topic was infertility and assisted reproduction and menopause. Is there any relationship between these two entities? So definitely there is a group of women, as we mentioned in my talk yesterday, that they have a poor ovarian response and they enter menopause early. So, and actually this is a significant portion of women. As Alessandra mentioned, now women in their 40s, they decide for their own reasons to have family. In order to see what is the ovarian reserve, because this physiology of the follicular recruitment, it's this has been mentioned yesterday, by using AMH and antral follicle count after she ends her menses in the beginning of her follicular phase. So the first case is a couple that she's coming in an IVF clinic. The woman is 42 years of age, and the man is 41 years of age. So they have a similar age. And the woman had 22 IVF cycles, unsuccessful in the previous 10 years. So she started having her first IVF when she was 32. And now she's 42, and after 22 attempts, there is no pregnancy so far. And unfortunately, in most IVF centers, they say, okay, you come here, let's have your FSH, LH, TSH, and your hysterosalpingogram to get the approval to get your medications, and then we will start. So in this case, the semen analysis of her husband, a recent one, is normal. Hysterosalpingogram that she brings, it looks normal endometrial cavity and patent fallopian tubes. Of course, one can say maybe she would need a hysteroscopy because she might have other abnormalities that she says that she never heard of the need of having this exam. She says that she has normal menses. Initially, she says she had menses every 28 days, but the last 3 years, she has her menses every 24 days. And actually, we can say that shortening of the duration is a sign of having diminished ovarian reserve. The first of the signs is the decrease in the menstrual cycle length. Her thyroid function is normal, prolactin levels are normal, and she brings her recent FSH levels, and it is 26. Her LH is 14. And she says that now she is relieved because she had another exam 4 months ago showing an FSH of 82, and actually her previous infertility specialist told her, now you are menopausal, and if you want to go ahead with an IVF attempt, we should use donor oocytes. Don't tell me that you've never been in front of a case like this. First of all, is it normal to have such a high FSH level of 82 and now become 26? The answer is yes, because these women can have fluctuating levels of FSH. And actually, even women who have established primary ovarian insufficiency with 2 FSH levels greater than 40, suddenly, after a period of time, they can have even normal FSH levels, or even with high FSH levels of up to 150, they can have ovulation, because for this particular group of women, the normal physiology does not exist. They have their own rules. So this can happen. She can have an FSH of 82 and subsequently an FSH of 26. However, it's true that she has diminished ovarian reserve. And actually, as we emphasized yesterday, we should check before actually there is a rise in FSH, because even when AMH is lower or when there is a decrease in antral follicle count, because once FSH levels go up, then it is probably already too late. So should we give a definition of repeated implantation failure because she had these 22 previous unsuccessful attempts? The answer is no, because in order to give the definition of repeated implantation failure, you must have normal ovarian reserve, you should have good embryos, and you should have normal endometrium. And this is something that it is completely different. It seems that in this woman, probably the reason for her multiple attempts, it was diminished ovarian reserve that she started 10 years ago. What is the question about having hysteroscopy? In general, after 3 attempts, one can say that yes, it is an option. However, for this particular patient at this age, I don't know how much it can help her. It is not wrong, but I don't know. Definitely she should have an hysteroscopy 10 years ago after her third failed attempt. Her AMH levels is, as expected, quite low. It's 1 nanogram per ml. And actually in her current transvaginal examination, actually we see no follicles in her ovaries. So what we should advise in this patient, and I think that it is good if we take some answers from the audience so it is more interesting.
Question or comments from the floor?
What was her mother's age when she entered menopause?
Actually, her mother's age was 55.
And sisters or other relatives, because or grandmother, because
She,
sometimes they
yes,
have a
you're right.
generation.
But she's an only child, so
Okay.
she cannot tell. What would you do? What would you tell this patient?
Can we go back to the former case, the one premenstrual syndrome?
The
Just
one
one
that you
second.
mentioned.
No, the one you were discussing before. You have presented 2 cases. The case before? No, just view the discussion, not with the slides. No. If there are no questions, I have questions for the first case. If you have experience with Aniocastus, that has good...
Can we see the first case from the previous one?
For the premenstrual syndrome, if you use, and which doses of magnesium, I use magnesium pedalate.
Everybody agrees that this is the first attempt.
So you do this as well? And do you use, in this difficult patient, you were mentioning the first one,
Let's see which is the first one.
Yes, exactly, thank you. So considering that she's so afraid, so to say, of hormones.
You mean this one?
Exactly. What do you suggest, first line and then second line, just because at the end of the day?
Yes. Okay. Of course, contemporary vitamin B, all these things, calcium, vitamin D, these are things that you can use for this woman.
But do you use routinely?
And yes,
Okay.
and paroxetine, yes.
And paroxetine, okay.
Although not prescribed, at least we're not allowed, but it is a first choice, at least during the luteal phase, yes.
Okay.
Are there any comments about these cases? Actually, since now we are in the premenstrual cases, do you want to discuss anything about these premenstrual case studies? Premenstrual syndrome case studies? No. So let's go back to the other one.
Okay. There is a question very important to ask to these patients that is another aspect that I see frequent and we do not pay attention too much in the clinical practice. How many hours do they sleep per night? Because now we have a multitask women having 2 children, employed, running all day, and they reduce dramatically the number of hours of sleep, sometimes less than 6. And this is a worsening factor of the premenstrual syndrome.
And
that
another
we don't
bad thing
ask.
in Greece is actually a lot of unemployment now. So a lot of
Okay,
people
so they
are
sleep,
losing.
you mean?
No, they're not sleeping at all because they have lost their jobs.
No, but anyway, ask about sleep because it is a great protector of mood, well-being, and immunitary function. So, and also, very important, shift workers, because shift workers have an increased vulnerability to premenstrual syndrome because the sleep pattern is continuously changed, particularly nurses. And even breast cancer risk is increasing in shift workers.
Exactly,
so.
but
Please,
unfortunately,
our
shift
colleagues-
workers
our
cannot change their
colleagues
shift.
and the journalists.
Are there any comments for this
Yes,
particular
yes,
patient?
Here.
I was thinking for the first case, for the premenstrual syndrome, since she was a high-risk woman, obese and all
Yeah,
these things,
yeah.
would you consider giving her Clara that has natural estrogen, 2 milligrams, that it is less risky compared to the estrogen that they have all the other contraceptives?
No, because Clara is also an oral contraception, and even for medical legal reasons, I would not consider any oral contraceptive pills because she has 2 risk factors and 2 reasons for contraindication for that. Okay. She is a heavy smoker and she's obese. So any contraceptive pill is contraindicated according to guidelines, so it would be a malpractice if something happens to this patient, even if she does not have any risk factor for thrombosis.
I agree 100%, and I want to endorse and stress this point at any age, by the way, because even in girls of 20, if they smoke 20 cigarettes, the risk of myocardial infarction, so even the arterial, increases by 10 times. So it's very important, that, as she very well did, to stress that it's a major contraindication to any contraceptive. They must quit or reduce dramatically smoke, otherwise really, if they have a thrombosis, we are really in very serious, but the most important is not illegal, is the fact that she has the risk of a thrombosis. So, contraindication, absolute, very well
Not
said.
only for deep
stress.
vein thrombosis, but also for arterial thrombosis.
Arterial thrombosis, in fact, that's
And
why I'm
endothelial
mentioning
dysfunction, yes.
myocardial. Yep. Yep. So, very important point.
Irini?
I have a question for this case. So, as you presented it, I see no other option than donor eggs. However, if she had normal menses, but let's say 24 days, and her FSH was 13, and she had 200 picograms of estradiol, and she also had some antral follicles, and she had an AMH of 0.5.
Actually,
What
it was
would you
one.
do?
It was even better for this
Okay.
one. First of all, I agree with you that we should not rush to saying, using donor oocytes, because a lot of these women do not even want to hear about having donor oocytes, and we have to respect that. For this particular patient, I would say that I don't see an indication for IVF because she has a diminished ovarian reserve, and it's not her answer. What we can tell her is that there is a small possibility for having spontaneous pregnancy, and actually we have seen that. Actually, by not having ovulation induction, they do better. I'm not suggesting of having a natural cycle IVF, but even just trying to conceive on her own, because during the last 10 years, she almost forgot how it is to have normal sexual function, because she's, every time she's scheduling her next IVF attempt. So I would say that we must have a discussion that she has to think her future childless, maybe adoption. She can have actually normal intercourse, or even by monitoring when she has a dominant follicle and it has a diameter of, let's say, 20 millimeters, have actually normal intercourse and see what is happening. And actually we have seen that. And I definitely don't think that there is a rush for going for donor oocyte, because under the Greek law, she is allowed to have an attempt with donor oocytes until she is reaching the age of 50. And because since she was 32, she had all these attempts or IVF, I would say just let her do on her own to have her normal ovarian function work, and see if she will have natural conception. Although small possibility, first of all.
A very important question that certainly you find in every consultation, that so often they don't have intercourse at all, or twice a month. That means nothing. They sometimes you say, oh, I don't want to ruin the IVF process, so they don't have any intimacy. So to restart from the scratch, to say, but the first way and natural way to conceive is just to have intercourse, but at least 2-3 times a week. Possibly not with the clock today because I have the FSH or LH peak, but because you have a tribe too. So this is...
And the point of Irini, I think it is very well taken. There is no need to rush to oocyte donation. Yeah. She can have some time, because until she's reaching the age of 50, she can have an attempt with a donor oocyte. We know that the possibility of having a successful IVF attempt using donor oocytes depends on the age of the donor and not of the recipient. And actually, there is more than 50% chance of having a pregnancy if you have good quality oocytes. So there is no rush to go to oocyte donation. She can exactly start to rethink of having a normal sexual function and have a normal life.
Do you have a question? Oh, sorry, because I saw your hand. Okay. You go ahead with your? No. Yes. So I think
Okay, and because now let's not, because I said I will stick to my 30 minutes, I will not discuss the last case or just present it quickly, like in 1 minute. Okay, the second case is a girl who is 22 years of age. She has amenorrhea for 4 months, and she says that she's having hot flashes the last month because she does not know the word hot flashes. She says that I feel hot during the last month. So because she's having amenorrhea, the basic diagnostic testing for her secondary amenorrhea is HCG, TSH, FSH, and prolactin. She has a negative pregnancy test. Her FSH is 155, and TSH and prolactin levels are normal. And in her transvaginal ultrasound examination, as you can see, we see no follicles. This does not mean that she does not have, but in this particular time, she does not have. And she has a very thin endometrium at this case. So she had a first diagnosis. She went to a first physician, and he told her that she is having a primary ovarian insufficiency, and she must go to do immediately ovulation induction and have oocyte freezing as we speak. This is what she heard, and don't tell me that you do not have patients like this, because I hear it all the time. So in her new testing, her FSH levels are 101, and AMH is, as expected, extremely low. It's 0.2, and because she's very concerned about her fertility, we tell her that if she wants to check for an ovulation, blah, 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 she must have a check for her FMR1 permutation if she's a carrier. And indeed, she's having the test, and she's having 85 CGG repeats. Actually, here in the first row is our head nurse, and she remembers Spiridula, the patient, that she had this counseling, and indeed she had. Actually, her mother was the carrier, and under a very detailed history, she could not reveal any case of a boy with mental retardation in her family. So this actually young girl, actually her mother became menopausal, if I remember well, at the age of 42. But in this she was much younger, and actually variable expression is something that we see quite often. So the reason for her primary ovarian insufficiency is fragile X permutations. So what is the what we should do for this patient? Actually, if this woman is ovulating and she's getting pregnant and she has a boy, there is a possibility of having a boy with mental retardation and having a fragile X syndrome. So at least in studies that we do for looking for ovarian function, fragile X permutations is an exclusion criterion to have the patients included in the study. However, if she gets pregnant, she has a girl, the probability is that probably she will have this permutation, but she will have only ovarian insufficiency, but she will be normal. But for boys, it is it's a problem. And actually, the proper person to do this counseling, it's not a gynecologist, but a genetic counselor, a geneticist who has this subspecialty and give the counseling for this patient. And we are happy that in Greece we have in Horemio a very good team.